Hello and welcome everyone to the Graduate School One Health Emerging Infectious Diseases webinar series. I am Paola Gamboa, Education and Digital Manager of the Graduate School. Thank you for being with us for this new session in our series, One Health Research in French Amazonia, led by Professor Loic Eppelboin. We are very happy to have you again and glad to know you are joining us from Chad, Tanzania, Cambodia, Algeria, Pakistan, Republic of Korea, Dominican Republic, Portugal, Italy, United Kingdom, French Guiana, and mainland France. I am delighted to introduce our chair for this session, Professor Loic Eppelboin, our expert in infectiology and epidemiology of infectious and tropical diseases. He is a full professor and a hospital practitioner in the Infectious and Tropical Diseases Unit at Cayenne Hospital, Centre André Rosemont in French Guiana. Today, we are particularly happy to welcome Professor Antoine Adenis, and on June the 24th, we will welcome Professor Paul Letournier. Remember that all our sessions take place at 12:30 p.m. Paris local time. Some quick reminders before we begin. The 40-minute presentation will be delivered in English, but you are welcome to ask your questions in English or in French. We appreciate your contribution. Feel free to share your thoughts in the chat at any time during the talk or during the discussion period. When the discussion begins, you are invited to turn on your camera and introduce yourself by sharing your name, your role, student, researcher, or other, institution, and the country you are joining us from. Keep in mind that the videos of the previous sessions are already available on the Graduate School website in the media section webinar series entry. Well, for now, I wish you to enjoy the session. Professor Eppelboin, you have the floor.
Thank you so much, Paola. Thanks to all to be here today, to be connected. I guess there was any technical problem. I hope that any person who want to connect will be able to. I'm very, very, very pleased to introduce today my colleague and friend Antoine Adenis, which is a professor in the Centre Hospitalier Universitaire of French Guiana. We've been knowing each other for almost 20 years, and when we met almost 20 years ago, we were both simple residents, and today I can have like a perspective on all his career. He started like a simple resident in medicine, and today he's the head chief of a very big institution of research on tropical medicine and epidemiology in French Guiana. And it was not something complete. The webinar was not complete without his intervention, because he's been working for a very, very long time on histoplasmosis in HIV patients for almost like also 20 years, a little bit less. And with the team, with Professor Mathieu Naché, with Professor Coupier, with many persons, they've been working on this thema. And today, French Guiana, thanks to them, is a real leader in the thema and in the topic of histoplasmosis and deep mycosis in HIV patients in South America. And they are sharing also their knowledge with other continents, as histoplasmosis is also discovered now in patients in Africa, for example, or in Cambodia. I will let Antoine present all these researches they've been conducting for years and years, and his participation was huge. So, Antoine, thank you so much to be here today, and it's a real pleasure to introduce you.
All right, so thanks, Loic, Paula, thank you. So thanks to the organizer for the graduate school for the invitation. I'm very glad to share my thoughts and experience and to show what was done with many people. So it's not one people, it's such a numerous number of people. So just moving to the next slide. So here's the title. It's Histo in people living with HIV, 20 years, French Guiana, elsewhere. It's an overview. So So I've been working in French Guiana for 20 years now, yes. And so my main topic is histo. And so covering different aspect of the disease, but we'll not show everything today, but most of them. So this is the outline. So we'll speak about the pathogen, the epidemiology, the clinics, the initiatives, a bit of stories, and trends, and the conclusion. So Histoplasma capsulatum is the causative pathogen for histoplasmosis. It is a thermally dimorphic fungus as a yeast in body tissue at body temperature, and as a mold in the environment. You can see on the right there the macro and microconidias attached to the ephae. This pathogen can be found almost everywhere in the environment, but there is a need for a media for the pathogen, for the fungus to grow. So the media is the soil that is enriched with bird bad droppings in chicken coops, or you can find it on like urban, rural, under roof, outside. So almost everywhere. So many areas of exposure. The taxonomy is moving now to 5 species, phenotypic species, and we do think now there are cryptic species, but this is also to be faced with the evolution of molecular epidemiology. And so as you study the different strains in different settings, you will discover new phylogenetic or lineage or clades, like species, worldwide distributed, geographically distributed. So this is questioning the dispersal, the spreading of histo through the years and then in the past. And so we thought it was maybe the air, the bats, but probably humans and any mammals are spreaders. And we just published last year a paper on the diversity, the high diversity of histo strains in the Amazon, and discovering also 2 new species there. So problem is that we have concerns at the moment regarding the implication of these findings in explaining the various clinical syndromes, in explaining the variation of virulence that some people are hypothesizing regarding virulence variation according to strains. But still, it helps a lot in the development of a more comprehensive dissemination model, revising the mandatory association with bird and bat droppings. And so now all mammals are considered as hosts, but also as spreaders. And a dead body infected in the environment can enrich the soil if you have a media for the fungus to grow, or even in urine or in feces, you can spread the disease. So this is probably why it is found almost everywhere. So we've been looking at this environmental exposure in French Guiana, and we've been describing a clear seasonality. So with the highest incidence by the end of the long dry season and the beginning of the short wet season. We've been looking also at trying to predict the clinical cases with time series using only environmental data, such as temperature, rainfall, and the ENSO index. And so we can predict almost 70% of the clinical cases observed in the cohort. So there is a major influence of the environment. So the pathophysiology of histo, so it's mainly an airborne disease, transplant-derived sometimes, and mother to child is more rare. So the microconidia will go to the lungs. Then you will have this primary phagocytosis. The fungus will change to a yeast within the cytoplasm of the cells, the white cells, and it will go to the phagosome. But it will inhibit the fusion with the lysosome, and it will survive within the cytoplasm of these white cells. And if you're able to manage the infection, you will have a granuloma in the tissue, and maybe a small lymph nodes in the mediastin. But if you're unable to manage it because of any immunosuppression, it will spread through the body within the white cells. So this is the way it goes. And so the underlying condition for histo is a major determinant of a symptomatic disease. And we can see so that the incidence is growing very fast as the CD4 count is moving down. So this is important to know and to remember, to keep in mind. And histo was said as the AIDS-defining condition from the very early onset of HIV pandemic in 1987, as the extrapulmonary form is an AIDS-defining condition. So who's at risk for histo? So almost everyone, the general population, children, elderly, workers at risk, transplant donors, travelers, any immunodeficiencies, so like monogenic ones, people living with HIV, so acquired immunodeficiencies, autoimmune disease, transplant recipients, chronic disease such as COPD, diabetes, people receiving any immunosuppressive therapies such as steroids, TNF blockers. So the main risk factors for symptomatic disease are any activities exposing to dust. So the level of inoculum is very important. The highest is the inoculum, the shortest the time to the onset of symptoms. The level of immunosuppression is also very important, as I said, with the CD4 count moving down, incidence going up. The absence of antiretrovirals, steroids, TNF blockers. The main risk factor for death are hemophagocytic lymphohistiocytosis, which is a very good killer. Any severity score, which is a proxy to organ failure, and time to antifungals also is a proxy to delayed diagnosis. So over time, the picture of histo has changed. So it was first described in the Panama Canal by Samuel Taylor Darling in 1905. It was described, and we need to remember this, in a case that appeared to be a miliary TB. But he didn't find any acid-fast bacilli in the cells, but he found small organism. He thought it was parasites, so he said it's maybe a plasma, like Plasmodium, and within the histiocytes, so histoplasma, and since there is a pseudocapsule around, histoplasma capsulatum. So then it goes, and with the opening of the tooth tomb and the people dying, it was suspected as the pharaoh's curse also. So it's kind of renowned for this, and then we had these studies around the world, like in the 50s, 60s, using histoplasmin skin test. So trying to see what's the burden in the general population of the disease. And we discovered that the histo was a very common disease, and was worldwide, responsible for outbreaks, and was mainly a self-limited disease. And then we moved to what we call the immunosuppression era, and the face of the disease changed to from outbreaks to stable numbers and increasing numbers of cases, mostly disseminated, fatal without treatment, and so mainly associated with HIV at the beginning. And now we have a switch to other immunosuppression condition like biotherapies. So nowadays, histo is listing among the high priority group of the WHO fungal priority pathogen list released in 2022. It's the top 5 pathogen requiring public health intervention, surveillance, R&D, innovation. So we have a roadmap, and it's quite new. So the classics on the disease burden is on the left, the map from the 60s, on the right, the map from the 2020s, which is quite the same in the end, but we can see a switch to the north, to the south. So it's considered as the first respiratory fungal infection worldwide, described in 60 countries, over 60, over 5 continents, with the Americas among the hotspots, and it's almost 5% of the world population exposed. So it's quite half the burden of diabetes worldwide, but it's quite big as in numbers. So just showing this just to recall people so that Histo is endemic in the Po River Valley in the northern part of Italy. So disease is in the soil, Histoplasma is in the soil, disease is there, but no one really know it. So, but beware. In Africa, things are moving very fast now. Many studies, many PhDs, many papers published. So knowledge is growing and things are moving fast. In India, it's like they are more like questioning, but so we can see also along the big rivers of the subcontinent, so that you have Histo there. In China also, it's like in between India and Africa, so it's moving quite fast, like in China, Cambodia, Thailand. So, but still challenging in many places. And also, Histo has been described in the soil and in the penguin excreta in the Antarctic Peninsula recently. So this is quite interesting. No studies in human people there, but mammals have Histo. So the burden of disease is really difficult to estimate, and we don't really know, and it's probably underestimate. But what's interesting is that the people working at this, they thought so on the right hand side, so that the percentage of death attributable to the fungal infection is around 80%, which is very high. So people assume out of our group so that disease is neglected and people are dying. So it's a problem. So we have very few data also out of HIV infected people. It's a problem. So data coming from the Transnet network said so that probably after transplantation, if you may have Histo, you will have Histo. Like median time to symptoms is less than 2 months, and almost 2/3 before 4 months. So it's quite early after transplantation. When using TNF blockers, so you have a few studies now and saying so there is something there. But if you screen those people with the antigen, if those people are asymptomatic, we don't really know what means a positive antigen, because people, most of them will have no symptoms in the future. So it's still questioning. So Histo is mainly studied in HIV people because the two areas at risk are overlapping. Because late HIV diagnosis and delayed Histo diagnosis are fueling respectively incidence and death. It's a problem because the late diagnosis is still there on any continent. The case fatality, the letalities could be very high, and we have this problem with the co-infection TB Histo, which is a nightmare. And so we have growing evidence using antigen detection on the burden of disease in various subgroup of interest. So it's ongoing. Knowledge is coming, and we have this problem of large screening of asymptomatic people with positive tests. We don't really know the meanings. Just quick statement. So this is in Latin America, but it could be in Africa. We have very high prevalence of co-occurrence of TB and Histo, and it's a very, very huge problem for the clinician. No clinical trials, no clear recommendation on the practices, drug-drug interactions. It's a nightmare. So looking at Latin America, so in Latin America, Histo is probably the first AIDS-defining condition and also the first cause of AIDS-related death. And it was stated as a neglected public health issue in 2013. So it's like 13 years ago now. And because we think of the Histo-like syndrome there. But disease is nowhere to be seen, few guidelines, lack of awareness, lack of access to diagnostics, lack of access to antifungals, lack of surveillance or absence of surveillance, confusion with TB, and this results in numerous numbers of avoidable AIDS-related death. And we do think so that in the Amazon, you have huge numbers of people that are victims of neglect since the onset of the HIV epidemic. So it's a problem there. So how do we come to the conclusion in French Guiana? So we knew since the 50s, so Histoplasma was in the soil. This was confirmed later on in 2012 with the map of Cayenne. We know that a third of the general population is exposed with this histoplasmin skin test study led in 1953, so a long time ago. From the 50s to the 80s, we have no really big information there because mostly on military people, but no large publication. And until the first case description in 1986 in ICU in a young Haitian patient with an AIDS syndrome dying from histoplasmosis. So then it was mainly a dermatologist and then a collaborative affair because the dermatologist described everything, look at the microscope, looking for leishmania, and they were finding histo. And then they make the linkage with the opening of the medical mycology facility lab with Professor Carm and Dr. Christine Aznar in Cayenne in 1995, with then molecular methods, BSL-3 facilities. And so together they build awareness, building so those histo-HIV database, so a very simple one using paper on the left. We have a cohort also with electronic data information system. This led to a major paper in 2008 describing the largest case series on histo in HIV. And with awareness and collaborative efforts between clinician biologists and epidemiologists, we impact the burden of disease over time with an increase in the number of cases and a very low lethality. So to date, we think histo is the first AIDS-defining condition, and data from the cohort will show this. This is stable over time. Histo is still the first AIDS-defining condition in the HIV cohort. If you look in those people with below 200 CD4 count, the prevalence is around 10% in the outpatients. We have very few cases described among immunocompetent individuals. Just a statement, no more comments. So, but we have very high incidence among inpatients with at the advanced stage of HIV disease. For example, in Western French Guiana, at the border with Suriname, the main diagnosis on discharge of inpatient with fever and HIV, if you have CD4 count below 200, histo represents almost half of cases. And if you have a CD4 count below 50, histo represents 86% of diagnosis on discharge. So it's very, very prevalent incident there. And so this was questioning us because on the left, you have this burden of disease, which is Saint-Laurent-du-Maroni. And on the other side of the river, you have Suriname. And our colleagues there, they said, no, we don't have any histo cases. It's not a problem. But we have very high mortality in AIDS in the hospital, so with TB. And so we had this rising question. So are neighboring countries sharing this similar burden of disease as us? So we published perspective piece reviews and then we built this study with Suriname. And so you can see in the middle down there, so that in inpatient with fever and or a suspicion of infection, 1/4 people are infected with histo. So it's a problem, and histo was probably also the first AIDS-defining condition there, responsible for death, but no one knows it at the moment. And this was led in the context of unawareness among reference centers across Latin America and the Caribbean. And this poster at CROI, the XASA network of large institutions studying mortality among TB patients, TB suspected or TB confirmed, stating on an 80% increase as out of AIDS-related death among patients with a culture negative TB, which is counterintuitive. So usually you die from the disease, so you're not dying more when you don't have the disease. But so they don't even cite histo. They say there might be another disease. So it is a problem. So we said we shall assume so that histo is a neglected top killer and a major issue because we share similar ecosystem with the surrounding countries, because we have we share high positivity levels of histoplasmy in skin tests, and because we also share high HIV prevalence levels across the America, we would say yes, so histo is a problem. So we've been modeling estimates because we need numbers in Latin America. And so the prevalence of histoplasma exposure in the general population was estimated over 30% in the general population in Latin America. So it's big. And it's one of the two countries with a number of histo cases in HIV that is superior or equal to the number of TB cases in those countries. And it's two of the three countries with a number of histo death that is superior or equal to the number of TB death in those countries too, according to a very conservative estimate. So it's very big problem. So we think so histo is responsible probably for a quarter to a fifth of AIDS-related death in Latin America. Authors said histo dethrones TB in Latin America. It's time to act. And so real life studies showed so that probably our conservative estimates is very far from the real incidence that was estimated 2 times our estimates in real life. So it is a problem. And this study also informed us so that we shouldn't only restrict a screening for histoplasmosis in those people with CD4 count below 200, because you will miss a lot. And histo can occur all the time during the life of people and during the disease evolution. So thinking of histo is key. And you can see the experience in French Guiana. So in blue, you can see the opening of the medical mycology lab resulted in a high number of cases, which is stable over time because of this late HIV diagnosis. And you can see in orange the lethality that is now very low, that resulted in awareness, trainings, capacity building, HIV care, but also antifungals like ambisome and aggressive strategies for the diagnosis and treatment. So looking at the clinics, we have 2 varieties of histo in humans. We have the one we call American one, which is Histoplasma capsulatum variety capsulatum, and we have the African one, which is Capsulatum duboisii. And duboisii has yeast that are much bigger than the capsulatum one, and we will see a few things later on. So those phenotypic aspects in the lab doesn't really match with the genetic description I present to you at the beginning. We have overlaps, and so we don't really match those information. So African histoplasmosis has phenotypic differences in the lab, but also clinical features that are specific with tropism for bones, lymph nodes, and cutaneous skin tropism. And we have those very specific exophytic verrucous lesion that we don't really see in the other one. And to date, this African histoplasmosis is not an AIDS-defining condition. So we'll go to the American one, which is the one we need to look at. Is a primarily pulmonary disease, as I said before, mainly airborne. We have a very wide spectrum of clinical features, and we have 2 pictures according to the underlying condition. You have the immunocompetent on one side, immunosuppressed. Immunocompetent disease is mostly asymptomatic. And immunosuppressed people, disease is mostly disseminated, severe, lead to death. Diagnosis in immunocompetent is mostly fortuitous, and in immunosuppressed rely on classical lab explorations. And in immunocompetent people, disease is mostly self-limited, no treatment out of severe cases. And immunosuppressed people, most of them, they need a treatment if they are symptomatic. So exposure to histoplasma is common, but symptomatic disease is uncommon. Most of the people will have no symptom or very mild illness, self-limited, never recognized. Incidental diagnosis on chest X-ray is the rule. You will find this nodule. Oh, it's a carcinoma. No, it's mainly only histo. And the picture change when the host is exposed to a massive inoculum or as an acquired or innate immunosuppression. You will have a rapid progress to acutely ill patients with distress, organ failure, and dissemination. So the pulmonary histo has two forms: an acute one, which is self-limited, sometimes associated with rheumatologic, dermatologic features. And this is a classification of the different case definition for acute pulmonary according to severity for antifungal guidance. So treatment is only recommended down there. And so you can have also a chronic one, which is observed in older people with cavity, so with this differential diagnosis with mycobacterial infection. And so, but I don't really even see this in French Guiana. You have large complications, very severe complication of chronic cavitary pulmonary histoplasmosis, which is a large, big problem to manage with. And so then you have this disseminated histo out of the acute pulmonary, which has different names: progressive disseminated, chronic progressive. But so it can involve any organ during the course of dissemination. Symptomatic disease could be rare at some sites. You have two pictures. Dissemination can be obvious with several sites with symptoms or signs. So like liver, lymph nodes, central nervous system. Or you can have a focal dissemination, a focal disease in a single organ. So you have these two pictures that are part of the disseminated histoplasmosis. So the risk factor for the dissemination is age, so the youngest people, and all these immunosuppression condition. And you have a risk stratification that was just published by the Infectious Disease Society of the Americas, So according to the type of the underlying immunosuppression, and you can see in the middle, so that HIV is always considered a risk factor for disseminated disease. So HIV/AIDS redefined the spectrum of illness from outbreaks to big numbers of cases. And the disease tends to be more severe there. And it can occur anytime during the course of HIV infection, as I said before, mostly below 200 CD4, and it's an defining condition. You need to think about it. So the clinical feature is mainly fever, malaise, anorexia, pulmonary, gastrointestinal, which is less known, and you need to think about this. Severe disease can occur in 10 to 20%. For example, in Western French Guiana, the typical picture is a subacute disease with fever and diarrhea. And if you perform a colonoscopy, you will find these small volcanoes, like nodules, ulcerated nodules in the colon, mostly in the right colon. And so, yes, think about performing colonoscopy. If you have abdominal pain or a diarrhea, you need to perform this. You will find a lot of histo cases. So you need to send a piece of tissue in saline solution to the lab, mycology lab for culture, and formalin to the pathology lab and ask for specific staining. So this is a few pictures of the wide spectrum of disease of histo. Don't forget the mouth. Look in the mouth. We think so in French Guiana, the experience is that cutaneous disease is a late manifestation of the disease, because as we are more aggressive for the diagnosis now, we don't even see cutaneous cases. The classics is lungs, sacrum, lymph nodes. So this is the classical picture. Histoplasma capsulatum can be found in the bones also as the same. And it can also mimic carcinomas in the lung, in the central nervous system. So in the lab, you may think about histo in front of cytopenias, liver tests, abnormalities with ASAT, ALAT, LDH increase, ferritinemia increase. Think about histo. It could be part of hemophagocytosis syndrome, which is very frequent, and histo is the main trigger of hemophagocytosis in HIV people in French Guiana. And hemophagocytosis is also a main risk factor for death in ICU, is the quicker killer in front of SOFA or time to treatment. So yeah, so once you go to the hemophagocytosis syndrome, it's really difficult to take back the patient even with ambisome. So we have many ways to perform the diagnosis. So we'll have a quick overlook of this. So we have a case definition. So the proven diagnosis rely on the classical direct examination and culture. It's the gold standard. The probable one is relying on antigen detection and molecular biology. PCR is a probable diagnosis to date. So proven histo relies on mycology, classical one, any tissue or samples, but not fixed in formalin. You need to send it in saline solution. You need a BSL-3 to protect the lab technician from infection. And median time to culture is slow, 2 weeks, 1 to 6 weeks, but median time 2 weeks. So it's so the conventional pathology you need to think about is very useful. You can find any like tuberculoid granuloma to anergia in the tissue. And if you do this silver staining, the Gomori Gorkat, which is the kind of the turquoise blue or the green on the right there, you can see those black things in the tissue, easy to see. This is the fungus, and it is histo and very easy to perform. So ask for these specific stainings in pathology. You will find a lot of histo. Probable histo, so it's antigen detection. A few industries have developed tests with high performance. We've been studying the IMI test in French Guiana. So when it's negative, it's a good prognostic, negative prognostic value. And when it's positive, maybe like if you have high prevalence level, it's very predictive of positivity, but in lowest prevalence level, it's you need to be careful of this. So we have now the lateral flow assays antigen detection from Miravista, which is an assured criteria test, very good one, like a pregnancy test performed in urine to date. But the concern now is the significance of a positive antigen test like latent infection in asymptomatic patients remain uncertain to date. So this is knowledge is moving. So it's very recent data. So we are exploring this to date. So findings still support so that we have a stratified approach for diagnosis, not perform indiscriminate multiple assay to anybody. So you need to look for people with probably symptomatic disease, mainly in immunocompromised people. You will find the disease and it will mean something, so need to treat. So some people also call for combining antibody antigen detection. So molecular methods, you have numerous of them, any type of samples. So it's moving. We have high diagnostic performance, but all tests are in-house, no commercial kits available. And one of them, the RT-qPCR, is moving to this standardization across settings with good performance, interesting in the treatment follow-up, in the decrease of the fungal burden, but the prognostic value is under study now. And we have those new generation assays that are coming, and so I think it's moving quite fast. We have an interferon gamma release assay, but it's also not like TB. It's just proof of concept. So the guidelines for the treatment mainly came from the Americas and the USA. Those guidelines have been updated recently. So immunocompetent people, out of severe cases, it's no treatment. And in immunocompromised people, it's treatment if it's at least symptomatic. There is a risk of progression. So here is the severe disease should be treated with liposomal amphotericin B, 3 milligram per kilogram, and with then itraconazole and for 12 months. And moderately mild to moderate disease should be treated with itraconazole orally, 600 milligram for 3 days, and then 400 milligram for 1 year. So so everything is built around severity, but the problem is that severity is not well defined in histo. So we've been working on defining a simple clinical score at the bed patients for clinician to decide within the two strategies in a robust and reproducible manner. So this is the external validation of the score is ongoing across Latin America. So iris is there, not that frequent, but there, source of high morbidity, but no mortality, which is the same in the literature. And we do think so that in the Amazon, at least, we think so that we should treat histo first, because histo is killing quicker, is most frequent in immunodepressed people at the advanced stage of HIV. And so we think we should look to an early probabilistic initiation of antifungal therapy, waiting for the results of the lab sampling and culture and direct examination. And so we are also questioning the level of death in those people receiving anti-TB therapy, because we still have a greater hazard of death there. So maybe we missed some of the people because we don't use today the antigen detection in French Guiana. So initiatives around the disease. So and trends. So as a main trends to date is that areas at risk are expanding. The environmental and climate change makes it suitable for the pathogen to survive, to grow to the north, to the south, to Antarctica. In places, so from surveillance data, you have cases in places we never saw histo before in hospitals, even in high settings countries used to screen for the disease. So, and if you use animals as sentinels, you will see so that now you have rodents that are positive for histo to Denmark in Europe. So it goes across the Alp mountains from northern part of Italy to the north to Denmark. So, and if you look in Gambia, for example, it's 80% of seroprevalence of positivity among horses in a place you have no cases among humans. So it can help you find cases in humans and endemic areas. But so this global burden is probably growing, also because these environmental changes, the anthropization, the increase of the world population, and also of the life expectancy, which is a problem for histo. And we have so resulting in an increase also in numbers of immunosuppressed individuals. So we think so that this susceptible population is increasing, and so we have probably a growing numbers. And people also call for a revision of the common concept of endemicity, because it's no longer a good one. Histo is not really geographically restricted. It seems so that it's moving in any place. So knowledge does not percolate because histo is still confused with other diseases, and notably TB, leading to diagnostic delays, notably these community-acquired pneumonia resistant antibiotics for a few days. And it's not only TB, it can be histo. So you need to think about it. And we saw so that there are cracks in the curriculum. Medical mycology is not that well performed and present in the medical books. Histo is the same. And so we need to increase these educational resources, clinical suspicion, patient outcome. We try to inform clinical practice to discriminate histo from TB, to use like any models for algorithm for the diagnosis, or even AI now is quite good also. And also discriminate severe from non-severe to guide antifungal practices, as I showed you before. Looking for TB, you will find histo. It's something we used to say. We took this from looking for gold, you'll find malaria in the Amazon. It's for us. It's if you look for TB, you may find histo. And remember, so that Darling said it was in a case that appeared to be a miliary tuberculosis at the right beginning of the disease. It was a problem in TB sanatorium in the US in the 20th century. In Africa now, they look for histo among those TB patients, and they find a high prevalence level. So we think we shall speak about the histo-like syndrome rather than the TB-like syndrome. And you can give second life to TB clinical trial samples in biobank, and you will find, such as this study in Ivory Coast, very high prevalence levels, such as the same as Suriname, like 25% of the people in a clinical trial that was published in New England, I think. And so no one knows about this. So we worked for 10 years on the road, and because on the left, we thought so that knowledge was like spotlight in the dark. You have these points. We need to link the points to see this big elephant on the right that anyone should see, but we need numbers to convince people. And so we go on the road, we met people across the Americas, in other settings, in Africa and everywhere, and try to convince. And it took 10 years to build this capacity. We had this technical cooperation among countries funded by PAHO, which gave us the support across the time. We managed to convince them to build frameworks, networks, a SWOT report on the situation analysis at the health authority levels. And so advocacy was leading to those big meetings with targets like 80 by 2020, 100 by 2025 for the percentage of lab equipped by these dates, working on tests, cost effectiveness, therapy estimates, editorials. This led also to initiatives, lab centralized initiative in Colombia, Guatemala, Brazil. Brazil showed a real increase in incidence, but not an unclear increase in survival of systematic screening, as I said. Systematic, you need to be symptomatic only, but patients on qualitative evaluation are quite happy with this rapid testing strategy. So we are now on clinical trials. So a phase 2 trial of a single dose has been shown to be safe and well tolerant. So now we move to a phase 3 trial. We'll have the results in 2 years of a single dose, 10 milligram, which is very simple and very effective. So we engage experts in fungal infections. Yes, j'ai bientôt fini, mon cher. Et so we move around the countries, and so we managed to gather people now in 2025 in a histoplasmosis working group with targets like 80, 80, 80, like UNH for HIV, but this is for fungal disease. And so we have now the roadmap published. So progressively, WHO engaged in the initiative with the mention of histo in the guidelines, the mention of itraconazole as an essential medicine, antigen detection in the tests, and the first guideline in 2020 for 50 years on histo that we managed to publish with the group down there. So we were very happy for this. And so now WHO is moving to this list of priority pathogens, tailoring at the regional scale, performing analysis for tests, and so engaging strategic funds and moving very deep in the organization to support this. So as a conclusion, so we've come a long way over the past 20 years. Still, histo remain neglected. We need efforts, continuing and collaborative efforts to make it a priority. We need to go over and much more R&D to hamper this increase, and probably also in numbers of cases, but also deaths. So we first think histo, and this is a feedback from a training in Africa. So the doctors were saying, so when TB is ruled out, histo should be considered as a relevant differential diagnosis. And moreover, when TB is confirmed, histo may still coexist and must not be overlooked. And the last lesson I will get to you from these people is that if it is not TB, it is not TB. So we need to think fungus and look for histo. Thank you.
Thank you so much, Antoine. Still very interesting. I've heard your talk several times, but every time it's more complete. Every time you made some new advances, new advocacies, new communication with people. And I like your last slide because I was in Senegal last year and they talked about histoplasmosis and you said everything that they have to think about it. They have to communicate, as you told me, like maybe 10 years ago, between infectiologists and mycologists, and so they will find histo. Okay, so is there any question in the public? And there are also questions in the chat, but maybe first there are some people who want to take the talk. Okay, so there is a question from Faiza. Her name seems to be iPhone, but maybe that's something else. Is primary histo in immunocompetent patients could be as a primary TB? I think you've almost responded, but maybe you want to complete.
Yeah. So the clinical picture and the chest X-ray picture is the same. So yeah, it's respiratory symptoms, but histo, as I said, is a self-limited one in immunocompetent people. So most of the time, people don't have time to get to the doctor so that the symptoms resolved. But if you perform a chest X-ray, you will see these nodules, the histoplasmoma, that can go to a cavity. And if you're not able to manage the infection, so yeah, so it's pretty the same, but not really the same in the end. But it looks like, and it's confounding.
There is another question. Should we have one effective updated rule to take care of histo in patients everywhere in France?
Well, should we have
one effective updated rule, maybe recommendation? I don't. Well, that is maybe Faiza is still online and she wants to ask something.
Yeah. So yeah, in France we have this expert recommendation in people living with HIV, which is, I think, the leading guidelines for histoplasmosis, because we have no, to my knowledge, guideline, the national guideline for fungal disease treatment, care and treatment in France. So we have the only one is in HIV people, and so we have collaboration with those people leading this, and so there is a group very specialized in infectious disease and medical mycology leading this. We've been interviewed. We were part of the initiative, so there are guidelines down there, but we don't have national guidelines, but there are international ones, and there's no reason we need to move over a different conclusion.
Thank you. There is a comment from Mike Brown from the UK. Excellent talk. Urinary histoplasma antigen testing is not available everywhere in UK, whereas serum beta-glucan is. Yes. Can you comment on this as a rule out? As a rule out test in immunocompromised patients with a histo-like syndrome.
Yes. So I didn't show it, but we worked before on the beta-glucan tests. So the test has very good past probabilities for a negative test. So if it's negative, it's good, but if it's positive, it is not specific. So so it's a test for fungal infection. So, but it's not for histo, and it's very expensive. So better use what we call the Biorad aspergillus, that is more sensitive and specific. And when compared to the beta-glucan, we showed so that the ROC curve showed a better discrimination than the beta-glucan, the fungital test, for example. But I cannot go over everything during the talk, so but yes, we've looked at this, and so prefer a less expensive test, and if you look for histo specifically.
There is a last question on the chat from Tait Edgard Zaina. Thank you for your presentation. So how can we integrate soil and wildlife habitat monitoring into hospital clinic diagnostic algorithm to anticipate and detect histoplasmosis more quickly in immunocompromised patients? That's a very difficult question.
Yeah, it is important. So I think first you should do meetings between vets, people working in the environment, and the clinician, and maybe you will inform each other on the knowledge you have on the disease, and then when you study the environment, maybe you will show proof to those clinicians who don't believe your statement, and you will show them, so disease is there, disease is in horses, disease is in these animals, whatever, and so maybe you should look for it, and maybe they will look for it, and if you share the information, if you know each other, this will be very, very virtuous. So we need to work together. It is how it works. It's together, stronger.
Any other question in people who are online?
I think there is one. I think there is one. Yes.
Anne-Marie, just go ahead.
So microphone is mute, Anne-Marie.
Would you can hear me?
Yes.
Yes, we can.
Maybe I missed the point about the changes in the environment. What is for you the main point about the changes in the environment, which might explain the rise of histoplasmosis?
So the main thing, I think, is that you have two trends moving together. Is that the global change makes it suitable for the pathogen to survive. So you need 20 degrees. So it's temperate. It's not very tropical. It's temperate. Mm-hmm. So with the global change, you have much more places to grow in the north or in the south. And at the same time, the humankind is occupying many more and new places. So the anthropization of the environment goes, so that the exposure probability is increasing because of the number of people and because of the number of areas at risk.
Okay, that's the two main factors, but there is nothing more specific in some countries, for instance, in Guyana.
No, it's in the environment. So so if there's no surveillance and no recommendation for people to get protected, so it's the same protection as for an antivirus. So you need to protect from breathing dust in the environment.
In caves or people or places apart from the human normal life.
Yeah. So you can breathe histo going to the market in French Guiana because it's in between houses.
In the market?
Yeah, because the wind will go in between those houses, and down there you have the media, you have histo there. So at the dry season, it is spread in the environment. It is the same in Indianapolis, and it's the same in everywhere. So yeah, histo is there. It's in the air, and it's in the dust. So you need to be aware of this and think about it.
And what, to wear masks all the time?
No, it's not necessary, because I said exposure is common, but symptoms is uncommon. Mm-hmm. So you need to think about the disease in a symptomatic people, to treat people early if they need it, and avoid severe and lethal syndromes.
Okay, your message is think about it.
Think of it and look for it.
Okay, thank you.
And the severity of the symptoms really depends of the inoculum. That's why many people are asymptomatic. Some people are just a very self-limited pneumonia. And sometimes you have a real ARDS, which leads to the intensive care unit. But in general, it's in people with a very high inoculum.
Thank you, Loic.
Maybe we will have to stop because it's almost over. Maybe a last question. I think like maybe Michael back now wanted to ask something. Michael, do you want to say something, or could we end this wonderful talk? Okay, Paul, I think it's time.
Hello. Good morning,
Maybe
everyone.
in French, as you want.
Somebody hear me?
Yes, we can hear you. Go ahead.
Yeah, I'm Mikhail Bakna. I'm from Chad. I'm biologist. Thanks.
Have you got a question?
No.
Okay.
Yeah, it's time for us to close. Sorry for the inconvenience we had in the beginning of the section with the link and all the technical problems. You will have the replay of this webinar on the graduate school media section. So thank you, Professor Adenis, for this sharp presentation, shedding light on your research on histoplasmosis. And thank you to you, Loic, for helping us connect with this wonderful group of researchers. Remember that next Wednesday, June the 24th, we will welcome Professor Paul Letournier, who will present his research on leptospirosis in French Amazonia. Thank you all for joining us and attending this monthly session. Loic, you want to say something else?
Yeah, we don't have the clear date today, but before the next talk on leptospirosis, we will try to perform a webinar on South American hantavirus and the specific research in French Amazonia on the Maripa strain. We don't have the date yet because we're looking for people to talk about it. But normally before June, we will propose to you a specific webinar on New World hantavirus, specific on the Amazonian strain.
Well, thank you all and see you next month. Bye.
Bye.